Renal system histology. Let us look at the embryological development in the beginning. And when we talk about the kidney, kidney will have two parts. So what are the two parts embryologically? Number one, it is the metanephric blastema, which is going to form the nephron, or what is also called as uriniferous tubules. These are the ones which will be forming urine. So urine formation, that is the first thing. Then what is the second part? Second part, you already have formed a urine and you want to collect it. So collecting system. And number two, the collecting system, as we are talking about, to collect the urine, it is given by ureteric bud. So ureteric bud actually embryologically will give 5 derivatives, and you can enumerate the 5 derivatives of ureteric bud which will be involved in urine collection. Let me repeat it once again. We are mentioning that embryologically kidney will have two parts. Number one, for urine formation. Number two, for urine collection. Number one, it is the metanephric blastema, which is going to form nephron or uriniferous tubules, which will form the urine. Once you have formed urine, you have to collect it. So for collecting system, number two, it is for the urine collection. You have to talk about the ureteric bud giving 5 derivatives, and those 5 derivatives you can see here. Number one, as you can put the numbers also. Number one is ureter, number two is renal pelvis, number three major calyx, number four minor calyx, number five collecting duct. So when the urine is already formed, it will be collected by collecting ducts given to the minor calyx, major calyx, and then from there it will go to renal pelvis, and from renal pelvis to the ureter and forward. You will see that all these 5 derivatives, they have transitional epithelium, which we will be talking about. But before we talk about transitional epithelium lining the collecting duct, what is the epithelium of nephron or uriniferous tubule? That is to be discussed. So we can talk about that. Plus here you should know that in the kidney there will be outer cortex and inner medulla, and in the cortex you will have the Bowman's capsule, PCT, DCT part of the nephron, whereas in the medulla you will have loop of Henle. And you will also see that once the urine is formed, it will be collected towards the medulla only into the collecting ducts. In fact, there will be some medullary pyramids here in this region, multiple medullary pyramids, and at the tip of multiple pyramids, the urine will be poured into the collecting ducts. So basically medulla will have these pyramids, and outer you will see that there is a cortex. We will have a diagram which will illustrate the same. Now let us look at the uriniferous tubule. When we are talking about uriniferous tubule or the nephron proper, what is the purpose? Urine formation. So what is urine? Urine is nothing but ultrafiltrate of blood. You bring the blood and it will be filtered as urine. It is to get rid of water from the body, but along with water some solutes also, sodium chloride, bicarbonates, and of course nitrogenous waste products, urea, ammonia, etc. So that is why you make urine, but most of the water, sodium chloride, HCO3 will be reabsorbed. 75% of it, of the filtrate, glomerular filtrate is reabsorbed, and it is well controlled. Reabsorbed mostly in the PCT, but it can happen in DCT also. DCT is depending upon two hormones, the aldosterone, which is secreted by adrenal cortex, zona glomerulosa, and ADH, which is secreted by the posterior pituitary. Basically it is given by posterior pituitary but secreted by the hypothalamic nuclei, basically the supraoptic nucleus, paraventricular nucleus. So that is about ADH. Both of them, what they are doing is they work on the distal part of the nephron like DCT, and they want to increase the water absorption, and they want to increase the solute also, solute absorption. Basically aldosterone works on solute and indirectly increases water absorption, so that there is more of body volume and more of blood pressure. They want to concentrate urine, basically that is the purpose of these two hormones when we talk about aldosterone or ADH. They want to conserve water, they want to conserve the solute, they increase the absorption, reabsorption basically, so that whatever urine is going out is having less of water and it is concentrated urine. You want to increase the blood volume, you want to increase the blood pressure. That is why these hormones are working. Now, looking at the histology thing, say this is the glomerulus. You will have one afferent arteriole, which is, afferent means arrival, so arrival means it is coming, and then there will be efferent arteriole. Efferent means outgoing, E for exit, E for efferent, so outgoing. So incoming, outgoing arterioles, where are they coming? What are they making? They make what is called as glomerulus. And what is glomerulus? It is tuft of capillaries, and these capillaries are fenestrated. Why they are fenestrated? Because you want to have ultrafiltered of blood. So where that ultrafiltered of blood will go? It will be going into this Bowman's capsule. This is the Bowman's capsule, and Bowman's capsule will collect that ultrafiltered blood, which is urine, giving it to what is called as the PCT. So this is the PCT, and then there will be a loop of Henle. As we told, the loop of Henle will be in the medulla. So kidney has two parts, outer is cortex. In the cortex you have PCT, DCT, and in the medulla you have loop of Henle. So where is DCT then? DCT will come here, this will be DCT, and then it will be becoming collecting ducts. It will be putting it into collecting duct, but collecting duct is collecting system basically. So that will be collecting duct, and collecting duct is not a part of nephron as such, it is part of collecting system coming from ureteric bud. So we are just showing that they will be connected like this. Now we have to remember, maybe it is the Bowman's capsule or the loop of Henle. Both of them will have same epithelium, which is simple squamous epithelium. You want simple squamous epithelium because thin filtration membrane and good exchange of filtration of the blood or the solutes or water. So when we look at the Bowman's capsule, even the capillary endothelium, so glomerulus is nothing but tuft of capillaries. So capillary epithelium, endothelium, or Bowman's capsule or this loop of Henle, they are simple squamous epithelium. Then what is this PCT and DCT? When you look at the PCT or you look at the DCT, both of them are actually simple cuboidal epithelium, single layer of cuboidal cells. So now when you say they are simple cuboidal epithelium, you will find one difference between the DCT, PCT. PCT will be having height equal to breadth, centrospherical nucleus, that is the feature of simple cuboidal epithelium, and it will have lot of microvilli of unequal height, so brush border. So microvilli of unequal height, brush border, to increase the surface area of absorption. And as I mentioned, PCT will be absorbing about 75% of water, sodium chloride, bicarbonate, etc. Though some absorption happens in the DCT also. If you look at the DCT, you will find that DCT is also height equal to breadth, centrospherical nucleus, so cuboidal epithelium, but very few microvilli. Now if microvilli are few, that means it is not brush border. So what is the similarity between this PCT and DCT? This is proximal convoluted, this is distal convoluted, because this is the loop of Henle. Loop of Henle is simple squamous epithelium and it is in the medulla, whereas the PCT and DCT, they are lined by the simple cuboidal epithelium and they are actually in the cortex outside. So they are in the cortex. This is the boundary line. PCT is cuboidal epithelium with unequal height of microvilli, so we say brush border. But this brush border is not in the DCT because DCT will have very few microvilli and cannot qualify as having brush border, but it also increases the surface area of absorption. So this is some basic idea we were having. There will be one juxtaglomerular apparatus also. You will find that at this level where this loop of Henle will have a thick ascending limb, which will be actually having low cuboidal cells, And when the thick ascending limb of the loop of Henle, this is the loop of Henle. So when the thick ascending limb of loop of Henle, which is lined by low cubital, meet with the DCT near the glomerulus, especially the afferent arteriole, there will be a juxtaglomerular apparatus. So we'll be talking about this juxtaglomerular apparatus also in detail. There will be three things to discuss. It is part of DCT, and there will be some cells in the DCT. It will be part contributed by the afferent arteriole, and partly the extraglomerular cells, which are called as cells of Lacey's, that also we will discuss. So this is the brief overview. Let us look at the slides. You can see this is the kidney, and kidney is having outer cortex and inner medulla. So outer cortex and inner medulla. As I mentioned, medulla will have renal pyramids. These are the renal pyramids. These are the renal pyramids. So this is in the deeper part or medulla part, and they have taken a section at the interface, magnified it, means partly in the cortex, partly in the medulla. So this part is the cortex and that part is the medulla. As is understood, the Bowman's capsule, PCT, and also the DCT. So this is the PCT and that is the DCT, and this is the Bowman's capsule. They will be in the adrenal cortex. Whereas if you look at the adrenal medulla below this, this is the renal medulla. If you look at the renal medulla, you will have this loop of Henle and collecting ducts, part of the collecting ducts. So this will be loop of Henle and part of the collecting duct, that will be in the medulla. Now, what is the lining epithelium of Bowman's capsule? As I mentioned, simple squamous epithelium, flat cell with flat nucleus or globular nucleus, flat cell with flat nucleus. So simple squamous epithelium you can write here. This type of epithelium is simple squamous epithelium, and it is present in the Bowman's capsule. Though the inner layer, visceral layer of cells will have podocytes. Podocytes means they'll have foot process and they form the filtration membrane. They cover the endothelium and they'll form filtration slits and for the filtration of blood. So as you can see here, there is one incoming arteriole, the afferent arteriole, there is one outgoing, the efferent arteriole, and as the blood vessel come, it will form this capillary, tuft of capillary, which is glomerulus. It will give the urine, which will then enter the PCT. This is the PCT. From PCT, urine will go to the loop of Henle. You see, loop of Henle is lined by simple squamous epithelium. Again, this is the lumen, and loop of Henle will have the flat cell with flat nucleus or globular nucleus. So it is a flat cell with flat nucleus or globular nucleus. This will be the loop of Henle. So as we are marking, this is the loop of Henle, though it is understood that most of the loop of Henle is lined by simple squamous, but thick ascending limb of loop of Henle is lined by low cubital. And when this thick ascending limb will meet with the DCT, that point you will look at one diagram, the juxtaglomerular apparatus. Juxtaglomerular means near the glomerulus. It will also include this afferent or the arriving arteriole along with the DCT. So what is the PCT lined by? PCT is lined by the cubital cells, and it will be height equal to breadth. There should be center spherical nucleus, though it is pushed to the surface area little bit because a lot of mitochondria are there in the PCT, but it is cubital epithelium and with irregularly height microvilli. So that is what we are telling brush border. And when you take a cut section of this PCT, you'll find that there are so many microvilli as you can draw here. As you draw it, you see they are the cubital cells, and these cubital cells, they have so many microvilli that the lumen become hazy. So lumen is hazy because of those microvilli, as you can notice here also. Now this is PCT. What about DCT? This is the DCT you are talking about now. So how it appears? DCT also is height equal to breadth, center spherical nucleus, but not brush border because microvilli are very few. So since the microvilli are very few microvilli, it is not brush border, the DCT. We are talking about DCT here. This was the PCT. And you will see that in the DCT, lumen is quite wide as compared with the PCT. And cells are low cuboidal. They are low cuboidal. So if you draw it yourself, you'll find that we are drawing the DCT now. DCT, you'll find cells are low cuboidal. You compare them with this PCT, compare this with this. So the lumen is wider as compared with this lumen, and it is not hazy, it is clear. Why the lumen is clear? Lumen is clear because doesn't have, lumen is wider and clear, and the cells are low cuboidal. We are talking about the DCT here. So it is because doesn't have microvilli, that is why it is not hazy. And what about the collecting ducts? As we look at the collecting ducts, you'll see that collecting ducts are lined by simple columnar epithelium. Simple columnar, as you can see, the height is more and breadth is less. So simple columnar epithelium, this is the lumen, and this is the place where you have the height equal to breadth. This is the height more than the breadth, the simple columnar cells, the collecting ducts. This is the place where you will have the aldosterone working, and this is the place where you will have the ADH working. They also work at the DCT. So DCT and the collecting ducts, you have aldosterone and ADH. Aldosterone will increase the sodium chloride absorption, so indirectly increasing the water absorption, whereas ADH works directly on water conservation. So antidiuretic hormone means it will reduce the diuresis, it will absorb water, so conserves water basically by working on DCT as well as the collecting ducts. Now the same thing you have taken in histology. In histology they can ask you diagrams. So how the glomerulus will appear? This is glomerulus, this is glomerulus, this is glomerulus, this is glomerulus, renal specimen and glomerulus. So what you will see in the glomerulus? See, this is tuft of capillaries, and not only it will have the capillaries, it will have this mesangial cells also, which is specialized connective tissue. So mesangial cells also specialized connective tissue, and this tuft of capillaries that will make the glomerulus. Glomerulus can be identified by the fact that around that will be a renal space. This is renal space where you will have urine. So this is the renal space in which you will have urine. You can see there is one renal space. It is written here, renal space, renal space, renal space. So around the tuft of capillaries you have renal space filled with urine. That is how you identify the glomerulus. Now how do you identify DCT? How do you identify PCT? First of all, you have to understand PCT is longer, it will have more sections, and DCT is shorter, it will have less number of sections. So what you see here mostly they are PCT, and there will be very few DCT, 1, 2, 3. DCT can be identified by the fact that they will be having wider lumen, low cuboidal cells, and darkly staining. So you will notice that darkly staining, like here you can see this is one DCT or this is one DCT, but PCT you can see now they are all PCT, proximal convergent tubule, and they'll have this haziness. In the lumen you will find some broken microvilli also. So that haziness which you can see here, this haziness, that haziness is all seen in the PCT. So number of PCT are more, and their lumen is not clear as the DCT. Let me zoom it here. So can you see the DCT? First of all, they'll have low cuboidal cells. They have low cuboidal cells. So automatically the lumen will become wider. They'll have low cuboidal cells, so automatically lumen will become wider. If you compare it with PCT, look at this PCT. Lumen is hazy. Look at this lumen, it is clear. This is hazy. And in the PCT, which you can see here also, we have marked the PCTs here. This is the PCT. This is the PCT. This is the PCT. The cells are cuboidal, but then the lumen is having this broken microvilli, you can say, and it is basically becoming not very clear, hazy lumen. That is PCT. Once you have this orientation, you can move further. We want to talk about juxtaglomerular apparatus, means it is sandwiched near the glomerulus, and for that purpose, you, as we have seen earlier also, see, this is the afferent arteriole bringing the blood capillaries, glomerulus, efferent arteriole taking the blood out. It is the afferent arteriole which is important in juxtaglomerular apparatus. Then you see, this is a Bowman's capsule which will have the urine. This is the PCT, as you can see, and then this was in the cortex. Now you are going into medulla. In the medulla you will have loop of Henle. So loop of Henle in the medulla. This loop of Henle will have a thick ascending limb of loop of Henle, which is simple cuboidal epithelium. Otherwise, the loop of Henle is basically simple squamous. Now, this simple cuboidal epithelium, as the thick ascending limb of loop of Henle meets with the DCT, that is the point where you will have the juxtaglomerular apparatus. And in the juxtaglomerular apparatus, you have to include this afferent arteriole also. Let me draw the three cells of juxtaglomerular apparatus. Number one, you should draw the DCT, distal convoluted tubule. In the distal convoluted tubule, normally we told that it will be low cuboidal cells. So these are low cuboidal cells, but these low cuboidal cells at juxtaglomerular apparatus will become columnar cells and densely arranged columnar cells. So densely arranged columnar cells, that is why they are called as macula densa. Macula densa, and they are looking for sodium chloride sensation, means sensors. They are sensors for whatever sodium chloride is there in the lumen of DCT. So basically, when we talk about the juxtaglomerular apparatus will have three type of cells. First of all, it is the macula densa cells, densely arranged cells, and these are the densely arranged cells, macula densa. They are columnar cells. They are sensing the sodium chloride in the lumen of DCT, number one. Then what is number two? Number two, you will find the afferent arteriole will have JG cell, juxtaglomerular cells, which secrete renin also. Renin, angiotensin, aldosterone system is activated. So where is JG cell? As we are telling, there is one afferent arteriole. So that afferent arteriole you can show now. As you are talking about the afferent arteriole, this is the afferent arteriole, it will have the smooth muscle cells in the wall, and they are the JG cells, and they will have this renin also. So afferent arteriole will be basically having these tunica media cells. The smooth muscles are in the tunica media, and they are the JG cells, and they'll have this renin, and they'll secrete the renin if there is less of blood pressure. So let us assume a situation there was less of blood pressure. So what happens is that the renin will be secreted, renin, angiotensin, aldosterone system, and you know aldosterone is for conservation of solutes. As it will conserve the solutes, it will conserve water also. As you will conserve the solute in water, there will be increased BP. So that is how it works. We started with low BP, and the renin was secreted by JG cell in the juxtaglomerular apparatus, and then renin, angiotensin, aldosterone system, and then there was conservation of solute and water. Solute means sodium chloride, all that. So along with sodium chloride, secondarily water will be absorbed, and you can increase the blood pressure, you can increase the body volume, the fluid volume of body also using aldosterone. But then among the two, there is a communicating cell which is communicating the information from DCT, the macula densa, to the JG cell, and this is number 3. As you are talking about number 3, it will be basically the extra glomerular mesangial cells, and they are called as cells of Lacey's. So you'll find that there is number one the macula densa in the DCT, number two the JG cells in the tunica media of afferent arteriole, and number three you have extraglomerular mesangial cell. A question came to you on that, the Lacey cell. Now, what is the purpose of Lacey cell? You can show the Lacey cell here. These are cluster of cells and pale staining cluster of cells, and they are just for communicating. What they do is they'll take the information from the DCT, which is a sensor for NaCl, and give this information to the juxtaglomerular cells which secrete renin. So the Lacey cells are basically the third cells which are for communicating purpose. Now you see, number one macula densa cells. Number one macula densa cell which were sensing the sodium chloride here. So this is the DCT now. Can you see the difference between DCT and PCT? See, this is PCT. It is having cuboidal cells, centrospherical nucleus, and the lumen is hazy. But DCT is having low cuboidal cells and lumen is clear. Look at this lumen, look at this lumen. This is the lumen of DCT, that is lumen of PCT. So you can differentiate between them. PCT are more in number, DCT are less in number. But here in this DCT, can you see in the wall, there is dense arrangement of the cells, and that is the macula densa, which will be basically checking for sodium chloride, it is sensor of sodium chloride. Same thing can be seen here. So this is the DCT. DCT normally will have low cuboidal cells, but here they have become columnar, and this is the macula densa. So macula densa is here. These are the cells of macula densa, and they are detecting sodium chloride in the lumen. Now, there will be these L cell or Lacey cells, which are cluster of cells pale staining. These are the cluster cells pale staining. They are the Lacey cells, and they will take the information from the DCT to this. What is this? This is the afferent arteriole. Afferent arteriole, lumen of afferent arteriole. In the tunica media, you have the JG cells. Same thing shown here. You see, this is the afferent arteriole making the glomerulus, and that is the efferent arteriole, which is taking the blood out. And when you take a section of the afferent arteriole, you found the JG cells. So these are the JG cells. They have a renin, they can secrete renin. So here in the afferent arteriole, you will have these nuclei, they belong to the JG cells. So these nuclei belong to macula densa in the DCT. These nuclei belong to the afferent arteriole, the tunica media, JG cells, and these nuclei belong to the Lacey cells. Why we want to know all that is because we got a question. This is your question, January 2025, FMGE exam, and they are asking identify the arrow marked cell in the renal biopsy. So identify the arrow marked cells in the renal biopsy image. Slow slide. You will notice that we are talking about cluster of cells which are pale staining as compared with the macula densa of DCT or the darker staining cells of afferent arteriole. So this is afferent arteriole, the JG cells. This is the DCT, so macula densa cells. They are neither pointing to macula densa, they are not pointing to JG cell. So what are they pointing to? They are pointing to these cells which are extraglomerular mesenchymal cells, and they are basically the cells which take the information from macula densa and give it to the JG cells. So they are cells of Lacey or extraglomerular mesangial cells. That is what we have to answer. So here we have answered it as extraglomerular mesangial cells or the cells of Lacey, which is basically for the communication purpose, and it is communication between the macula densa cell, which will sense the sodium chloride in the glomerular filtrate and give it to the Lacey cell. Lacey cell will give it to JG cell, which will then secrete renin, and you can activate the renin angiotensin system depending upon whether the BP is low or high. You can modulate. Now, why you are not taking answers macula densa? Because macula densa are here. These are the nuclei of macula densa in the DCT. So, arrow mark is here. Why you are not taking answers podocyte? Podocytes will be lining the capillary endothelium. They will have foot process and they are the visceral surface of the glomerulus. This is the glomerulus, you see. Outer layer of glomerulus cell, parietal layer is simple squamous epithelium. As we told, Bowman's capsule will have outer layer. This is the space we are talking about, renal space. Here, ultrafiltrate of blood will come, that is the renal space. So, urine will be here, the ultrafiltrate of blood. And the inner, they would be the podocytes. So, podocytes are here. That is not the marker you are putting. Marker is on extraglomerular lacy cells. Then why not JG cell? JG cell are here. This is the afferent arteriole. These are the nuclei of JG cells. So you are not marking the JG cells here. You are marking extraglomerular lacy cells. So we'll keep our answer as choice number C. And as you go on to the next part of the discussion, transitional epithelium lines the collecting ducts. First of all, we'll see that how transitional epithelium is identified and where it is lining. It is lining the collecting ducts. Starts with collecting ducts, and as we have told, there are 5 derivatives. What are the 5 derivatives? Ureter, pelvis, major calyx, minor calyx, collecting ducts. They are the 5 derivatives of ureteric bud, and that is for collection of system. That is where you will have transitional epithelium. Transitional epithelium is identified by the fact that this is the basement membrane. It is multi-layered, but the topmost cells are very large. They can be binucleated also, and they are dome shape. They protrude into the lumen, and they can be umbrella shape also. So if you look at these cells, the topmost cells, they'll be umbrella shape cells, 2 nuclei, dome shape, umbrella shape, and under that you can see several other nuclei. They have stretchable membrane, and they can stretch like in urinary bladder. If there is more of urine, they can stretch to accommodate more of urine. They can be 8 to 10 cell thick, but if you have urine, they have stretch, they can become 3 to 4 layers. So layers can reduce. This is transitional epithelium. So where do you see transitional epithelium? Let us draw the diagram. You will notice that this is the collecting ducts which have collected the urine, and collecting ducts will collect the urine into minor calyx. From minor calyx it will go to major calyx. From major calyx it will go to renal pelvis. From renal pelvis it will go to the ureter. So these are the 5 derivatives of ureteric bud. Number 1, ureter, renal pelvis number 2, major calyx number 3, minor calyx number 4, collecting ducts number 5. All of them are lined by transitional epithelium. But where the transitional epithelium begins? Transitional epithelium begins at the tip of the collecting ducts. Remember that collecting ducts themselves are lined by simple columnar epithelium. If a question comes, what is collecting duct lined by? You should say simple columnar epithelium. Then where is transitional epithelium? Actually, transitional epithelium begins here, but transitional epithelium is lining very little bit of it, the tip of collecting ducts. Point is, if a question comes, what is collecting ducts lined by? First answer is simple columnar, and then second answer is transitional epithelium. So transitional epithelium begins here. Now, if transitional epithelium has begun here, then where is it going from there? To the minor calyx, to the major calyx, to the renal pelvis, to the ureter. So all of them will be lined by transitional epithelium. Actually, beyond that also, you will follow that this is the urinary bladder. This is urethra. Let us discuss male urethra. This is male urethra passing through prostate. So you'll have the prostatic urethra. This will be prostatic urethra inside. Passing through deep perineal pouch. When it passes through deep perineal pouch, you'll have membranous urethra. And below this superficial perineal pouch, you'll have sponge urethra. And this is the opening through which this is the external urethral meatus. External urethral meatus, where the urine will come out. And let us show the ureter also. This is ureter, which is bringing the urine. So we want to know where all places the transitional epithelium is. It is at the tip of collecting ducts, minor calyx, major calyx, renal pelvis, ureter. So this ureter has come, and it is having transitional epithelium. Now this transitional epithelium not only is there in the ureter, it is also on the urinary bladder and till the proximal half of prostatic urethra. Till the proximal half of prostatic urethra. So transitional epithelium is till the proximal half of prostatic urethra. It is the lining urinary bladder and ureter. What is in the distal half of the prostatic urethra? What is in the membranous urethra? What is in the spongy urethra? What is at the external urethral meatus? Now remember, when you talk about urethra, especially male urethra, it will have three epithelium. Beginning, it is transitional epithelium. Most of the male urethra is lined by stratified columnar epithelium, and any external opening is lined by stratified squamous epithelium. Stratified squamous epithelium, because it is urethra, so it is wet, so it will be non-keratinized here at the opening. So my point is, proximal half of prostatic urethra was lined by transitional epithelium, and the external urethral meatus is lined by stratified squamous epithelium, non-keratinized because it is wet. Then where is stratified columnar? Rest of the urethra. And what is the rest of urethra? You can mark it and you can tell this urethra, the lower half of the prostatic urethra, the membranous urethra, the spongy urethra, which is going to penile shaft also. All this will be stratified columnar epithelium. Now, if that is stratified columnar epithelium, then where is the transitional epithelium? Transitional epithelium was up here, proximal half of prostatic urethra. Proximal half of prostatic urethra, you have transitional epithelium here. And what is lining the distal external urethral meatus? That is stratified squamous non-keratinized epithelium. So let me repeat, the male urethra is long, it is 20 centimeter long. See, all these are MCQs, all of these are MCQs, each one, the statement which you make are MCQs. So where is the transitional epithelium? Only at the proximal half of prostatic urethra. Then where is stratified columnar epithelium? It is in the distal half of prostatic urethra, in the membranous urethra, in most of the spongy urethra. It is stratified columnar. Then where is stratified squamous non-keratinized? Only at the external urethral meatus. That is about the epithelial lining of the male urethra.